Good evening, can you hear me? Uh, Very warm welcome to the uh, postgraduates and a very warm welcome to Dr. Sunil, MS, Assistant Professor, RIO Trivandrum, Dr. Divya, who's a retina consultant at Contrast Eye Hospital, who will be moderating the event. Now I hand over the mic to Dr. Mihir to continue the proceedings.
So, welcome to the third module of our PG Buster exam buster programs. So, third module, and today we have interesting topics on retina, that is fluorescein angiogram and the OCT of the macula. So, we have with us today Dr. Sunil. So, Dr. Sunil has been my mentor during my PG days. He's a very methodic teacher, a great surgeon, and a very good academician. His area of interest is medical retina. He has humbly accepted our request to take this class. He's currently the assistant professor in the retina department at RIO Trivandrum. So without wasting much time, I will hand over the meeting to Dr. Divya. She is going to moderate this meeting. Okay. Dr. Sir, Sunil sir, you can start your talk. Dr.
I that is better because I have already wasted 10 minutes and okay.
Yeah. Sure.
Yeah. So thank you, Dr. Mihir, for this nice introduction. So actually, this talk was planned around 3 weeks back when Dr. Mihir called me and told me such a talk is there. I was not much familiar with the teaching outside our classroom teaching. So I used to see this fantastic talk in CMEs and all, but I was thinking why Mihir called me for this talk. Anyway, I don't think I can. I'm a very good teacher, but I will just try to analyze this topic and make it little easy for you, so that I think may be beneficial in your profession. Okay, the first half of our topic is, our talk is maybe in another 20 minutes time, we will be talking on fluorescent angiogram. So fluorescence, fluorescence is the property of certain molecules to emit light energy of a longer wavelength when stimulated by light of shorter wavelength. So using fluorescein angiography, we are actually using a molecule called sodium fluorescein. It actually absorbs blue light that you are giving and emits green light. Okay, usually we will give 3 ml of a 20% solution which is available to us into the cubital vein, and serial photographs are taken at approximately 1 second interval between 5 and 25 seconds after the injection. So serial photographs are taken at 1 second interval. Late photograph are taken at 10 minutes after the injection. Somebody talks about a late film. That means the film has to be at around 10 minutes. I think this usually some examiners, especially for the DNB exam, they ask you late film means what? That is a film taken at 10 minutes after the injection. The fluorescein that you are injecting in the cubital vein, 80% of it is plasma protein bound and is not available for fluorescence. Only 20% of the unbound fluorescein that is available is responsible for the fluorescence that you see during angiographic procedure. So 80% of fluorescence that you give is not available for your fluorescence property, but only 20% is available. So I'm just telling this because for you to understand the angiogram, you have to have baseline information on this. So you give dye and then you give a white light into the eye through a filter called the excitation filter, which will allow only the blue light to go, which will allow only the blue light from the white light to go inside. It will strike on the structures and come back. These structures will absorb this blue light and emit green light, which is captured into the camera through a filter, which will allow only the green light to pass backwards into the camera and blocks all the blue light, which is reflected from the retina. So that is what happens. So to understand normal fluorescent angiogram, there are a few phases for it. One is a choroidal phase. Second is the arterial phase. That means that when the dye comes into the choroid, when the dye comes into the artery, then the dye comes into the vein from the artery. That is called the arteriovenous phase, which is early and late. Then the recirculation phase and the late phase. So choroidal phase begins around 10 to 12 seconds after the injection of dye into the cubital vein. Once you give into the cubital vein, you see a white flush into the choroid. That is called choroidal flush, and that is seen around 10 to 12 seconds after your dye injection. You can see this at this time you will see, I don't know whether you are able to see it, you will see a white flush of the choroid. So that occurs around 10 seconds after your dye injection. But sometimes it will be delayed. There are pathologies related to it. So when you give the dye, you will see just a black color, which will change into a flush white color. Now from the artery, from the choroid, the dye enters into the artery by around 1 to 3 seconds. The artery first fills the central lateral artery, and then dye fills into the periphery of the artery, goes into the arteriole, capillaries, and then into the postcapillary venules. So you look at this. The dye has entered into the capillary, into the artery. Dye is going into the periphery now. So it is going into the arteriole, then into the vein, and into the capillaries and into the venules. Now from there, the dye enters in the venous system. The fluorescein from the smaller venules enters the veins along their walls, because the velocity of the blood is higher in the center, so that the dye is pushed towards the periphery initially. So you see the laminar flow. You see now the dye start coming in the vein along its edges, and then comes towards the disc. So it is become more prominent. It is getting this along the vein. It is coming into the disc. So it is going along the artery peripherally, coming back into the vein along the vein into the disc. So this is called the arteriovenous phase, the arteriovenous phase of the angiogram. So what will happen? Sometimes you will have two veins joining together, and you see sometimes a trilaminar flow through the veins. So late arteriovenous phase, dye completely fills the lumen of the vein. In the late arteriovenous phase, dye is completely filling the lumen, and it occurs around 25 seconds after the dye injection. It is at this stage you will see the perifoveal capillary network very well. You see the dye has completely filled the vein. It has gone along the artery peripherally, come back along the vein laminar flow, and now completely filled. It occurs around 10 to 25 seconds after the dye injection. It is at this stage you will see the perifoveal capillary network very well. And the fovea appears hypofluorescence because the foveal avascular zone, the vessels are not there, retinal vessels are not there over the fovea, and moreover, the tall retinal pigment epithelium containing pigments blocks the choroidal flush. So that is why the foveal avascular zone is appearing dark. Now so very important landmark, the dye comes into the choroid by around 10 to 12 seconds. Then the dye completely fills the vein by around 25 seconds after the dye injection. Now there is a phase called recirculation phase, which begins about 30 seconds after the dye injection. In this phase, the fluorescence in the you can see that the brightness of the vessel has now decreased. This is because the fluorescent content in the blood is reduced because of the recirculation. So it begins around 30 seconds after the dye injection. Late phase means the phase of fluorescein angiogram where you take a film by 10 minutes after the injection. It is at this stage your disc getting stained. Okay, so that is late phase. So very important landmarks. 10 to 15 seconds after the dye injection, dye comes to the choroid. From the artery to the vein, 3 to 5 seconds. The complete choroidal filling occurs. Around 1 to 2 seconds after the dye comes into the choroid, it comes to the artery. Then into the vein, it comes around 8 to 12 seconds. So from the injection, the complete filling of the vein occurs by around 20-25 seconds. So to understand this angiogram, you have to have, when somebody talks about angiogram, they will be talking on hypofluorescence and hyperfluorescence. Okay. So if you know these terms, you can interpret any angiogram. I will be showing you angiograms which are just being shown in an exam. So hypofluorescence may be block fluorescence or a filling defect. Hyperfluorescence may be a transmitted fluorescence, a leakage, pooling, staining. As a postgraduate, I used to have always confusion on leakage, pooling, and all. But now I can show you what is the meaning of each one of these. Block fluorescence. Look at this bleed here. This is a pre-retinal bleed. You cannot even see the retinal vessel. Forget about the choroid. So this is blocking both the retinal circulation and the choroidal circulation. Look at the angiogram. See this. This is blocking the retinal vessel, choroidal circulation. You cannot see the retina. You cannot see the choroid. So this is a block fluorescence. But look at this bleeding here. Actually, you can see retinal vessel growing above this. There was a bleeding here. That is a subretinal blood. So actually, you can see the retinal vessel going above his eye. So this is a subretinal bleed, which is blocking the coronal, vasculature, but not the arterial vasculature. So this again is a block fluorescence, but this is blocking completely the retina and the choroid. This is blocking only the choroid, but this is block fluorescence. Now another, so this is hypofluorescence. This is called hypofluorescence, blocking the other structures. Another cause of hypofluorescence is a filling defect. See, for the dye for the choroid or the visualization of the retinal capillaries is very important. Suppose if the venous stasis occurs, there is capillary ischemia, and so capillary non-perfusion areas here. So these areas where there is no blood reaching appears as hypofluorescence. So hypofluorescence may be either block fluorescence or maybe the capillary non-perfusion areas. But look at this this area. This is an area of geographical atrophy where there is RPE is lost. So when you give angiogram, you are having a window open here. There is no RPE. You can directly look into the choroid. So this is hyperfluorescence due to transmitted. That is called a transmitted fluorescence or the window defect, because there is no RPE. You are visualizing the choroid. The another cause of hyperfluorescence is actually leakage. Look at this. There is a neovascularization which is leaking during the angiographic procedure, and as the angiogram proceeds, the margins of this intensity of this hyperfluorescence increases and the margins become fuzzy. That is leakage. Mind you, this is the hyperfluorescence increases in size and its margins are becoming fuzzy. Okay, its size increases, margins become fuzzy. That is leakage. Here again, this is an angiogram of central serous retinopathy. Initially, this leak starts like this. As the angiogram proceeds, it will become large. So it is increasing in size. So that is leakage. But what is pooling? Look at this. These are pigment epithelial defects. So you can see the hyperfluorescence is there inside this pigment epithelial detachment. And as the angiogram proceeds, only the intensity increases and its size does not increase. Okay, so that is pooling of the dye. Pooling means the dye getting collected inside anatomical spaces. Its size does not, so cannot increase. So now you look at this, the angiogram of a central serous retinopathy. Initially, there's a leak starting here. It is enlarging. So this is a leak of the CSR in the fluorescent angiogram. But this is a detached area of the central serous retinopathy. You can see there is a white color here. There is a fluorescence here. So this is actually because the dye is actually filling or getting collected in the fluid here. So this is again pooling of the dye. So this again is a collection of the dye in an anatomical space. So that is the difference of pooling and leakage. Here again, you see another angiogram of a disease called VKH, where you see multiple leaks here. But you can also look out, if you look at carefully, there is a serous detachment here. The dye is getting collected here. Okay. You can see a white color here in the serous detachment. So that is the difference between leakage and pooling. Leakage means that as the angiogram proceeds, the size of the lesion increases, its margins become fuzzy. But in a pooling, you will see that the intensity of the lesion of the hyperfluorescence increases, but its margins will remain exactly the same. So that is pooling. So now staining. See, this is an angiogram of a patient who had a scar at the fovea. As the angiogram proceeds, see, initially you can make out this is a scar. This entire area is a scar. As the angiogram proceeds, even in the late phases, the size of the lesion does not get increase. Actually, the scar tissue is getting just stained. So this is called staining, another cause of hyperfluorescence. So what is important for us is to differentiate between leakage and pooling. Leakage means the size of the lesion, its intensity and size increases. While in pooling, only the intensity increases, but the size remaining same. Now we will look at some of the situations where this is again commonly asked for your exam. Situations where you should avoid fluorescent angiogram. Can you do fluorescent angiogram in pregnancy? This was a question in DNB exams. Yes, theoretically you can do because fluorescent does not cross the placenta. Renal failure, yes, fluorescent is not toxic to the glomerulus, so theoretically you can do fluorescent angiogram in renal failure, and no dose adjustments are required. But majority of us are afraid to do in pregnancy and in renal failure. But theoretically we can do. But mind you, you should, as far as possible, avoid fluorescein angiogram in history of allergy to fluorescein. A patient who had done fluorescein previously had some allergy, never repeat fluorescein angiogram because it may produce anaphylactic reaction. Mind you, very careful, patients who are having asthma, you should, as far as possible, avoid fluorescein angiogram because this can induce anaphylaxis. But this is the this is what I have have basics for your for you to understand angiogram. Now I will be showing 4 or 5 cases which are just often asked in an exam, whether it's a DMB, either DNB exam or an MS exam or a FRCS exam. Fluorescein angiogram is a station for you. So you have to have a clear understanding of this. And thing is that you can predict what is going to be asked in an exam. Okay, which are conditions. So we will be discussing only that conditions. So first condition that you are likely to get as a fluorescein angiogram is diabetes, especially diabetic maculopathy. Look at this fluorescein angiogram. This patient, you see the fundus, you are having a few hemorrhages probably here. You have a few microaneurysms here and some hard, exudates here. And the fovea is relatively okay. So this patient, look at the fluorescein angiogram, you see glistening spots. So you know these glistening spots are actually microaneurysms that are leaking. So the red ones which are leaking are seen as microaneurysms which are leaking here. So your confusion is over whether this is microaneurysm or whether this is hemorrhage. This is actually leaks, while these small hemorrhages you can see black blocked fluorescence here. Okay, so hemorrhages can be differentiated from microaneurysms by fluorescein angiogram. Actually, you will see more microaneurysms on fluorescein angiogram than when we see fundus. So as the angiogram proceeds, the leak increases. So it is very important to find out these microaneurysms and leak while you do fluorescein angiogram, while you treat patients with a diabetic retinopathy. So this is a focal lesion. The microaneurysm is just leaking, so it is called a focal leak. So that is a focal maculopathy. Look at this patient. It's actually the microaneurysm that is leaking. Okay, but look at this patient. Here you see a few hemorrhages. You are probably there may be microaneurysms, but when you do fluorescein angiogram, you see a diffuse leak. This is not like a leak from a micro. There are probably a few microaneurysms here, but this is a leak from something else, not from a microaneurysm. So these are actually leaks from dilated capillaries. So it's diffusely leaking. So that is called diffuse maculopathy. And look at this patient here. You are having circinate exudate with some probably some microaneurysms or hemorrhage here. When you do angiogram, you see multiple microaneurysms, stars-like things, hyperfluorescent area. These are microaneurysms. But look at this part of the angiogram. You are seeing something leak from capillaries, because it is diffuse. So it has got focal leaks from a microaneurysm and diffuse leak from dilated capillaries. So these are diffuse combination of diffuse combined and diffuse maculopathy. And this, you see this patient, very ischemic clinical evidence because there is cotton wool spots here. So when you do angiogram, you see there are ischemic areas here. You see whatever you see black are ischemic. You can see the foveal avascular zone is enlarged. So this is ischemic maculopathy. So that is diabetic maculopathy. Actually, you can differentiate into focal, diffuse, and ischemic maculopathy. Why should we do fluorescein angiogram in maculopathy? Is because if you are going to treat patients with lasers, for example, as of now, center involving maculopathy, actually treatment is intravitreal anti-VEGF agents or intravitreal injections, while non-center involving edema, like what you see here, actually can be treated with laser. But if you do with lasers, you should rule out ischemic maculopathy before giving lasers, because if you give lasers, this capillary, this ischemia may worsen. So you can rule out ischemic maculopathy only by a fluorescein angiogram. So that is why in diabetic macular edema, you have to do a fluorescein angiogram. Look at this patient. This patient had undergone uneventful cataract surgery. He had diabetes, but 1 month, till 1 month, he had 6/6 vision. Later, after 1 month, then he suddenly dropped his vision. Fluorescein angiogram revealed something called a cystoid macular edema. You can see a flower petal pattern of angiogram. He had diabetes, but his vision dropped. He probably having 1 or 2 microaneurysms. We don't know whether he's diabetic maculopathy or whether it is whether diabetes is producing problem or whether his cataract surgery is producing problem. So this has revealed a flower petal pattern, not much fundus finding, angiographic findings of diabetic retinopathy. So you can label this as a cystoid macular edema following surgery. But look at another patient who had a few findings, few microaneurysms here and hard exudates here. Your very few findings actually. This very few findings, and you can see the red-free photograph also shows some hemorrhage and some hard exudates. So when you do angiogram, you see there is actually diffuse leakage. So the capillaries are leaking extensively, and there is a stored macular edema. So now you know this is diabetic retinopathy producing cystoid macular edema, not the cystoid macular edema of postoperative or the Irving-Guest syndrome. So you can differentiate in a patient whether this is pseudophakic macular edema, cystoid macular edema, or a macular edema of diabetes. So you can differentiate. This is a feature of diffuse macular edemas where there may not be much findings on the fundus, but you will see angiogram there is extensive diffuse leak. It's not microaneurysm, the diffuse. So that is diffuse macular edema with CME. Now, another situation where you have to do angiogram is you are not able to see the fundus. You are in doubt whether there is PDR or not. This is a case of astroid halosis. You cannot even make a reasonable judgment of the grade of diabetic retinopathy in this patient. So actually what you can do a fluorescein angiogram. So fluorescein angiogram will pick up all these neovascularization, extensive neovascularization when you look at the fundus. Okay, so that is what happens. So you can do fluorescein angiogram in patients with patients where you suspect proliferative diabetic retinopathy, but you are not able to have a clear fundus view. So you can do a fluorescein angiogram. So the indication is in hazy medias where you suspect PDR, you have to do angiogram. Or in patient, look at this patient. This patient has already undergone some macular photocoagulation, but you are in suspicion. So you did a fluorescein angiogram. You can see that there is neovascularization, which is leaking extensively. So this patient actually requires pan-retinal photocoagulation. So here, this is to detect subtle NBEs, which are missing clinical examination, can be picked up by fluorescein angiogram. So you have to rule out an ischemic maculopathy. You can do to find hazy medias, or you want to pick up subtle NBEs. You can do fluorescein angiogram. So this is also being used generally asked in exam. What are the indications for your fluorescein angiogram in these diabetic patients? Now, another common question that you will get is the fluorescein angiogram of central serous chorioretinopathy. Look at this patient complaining, young, anxious, male patient complaining of a scotoma. You can see a serous detachment here. When you do fluorescein angiogram, in the arteriovenous phase of the angiogram, look at the angiogram. There is dye in the artery, there is dye in the vein. This is the arteriovenous phase of the angiogram. The early arteriovenous phase of the angiogram, you see a leak which is starting there, which is extending, and is becoming a smokestack pattern. So the dye is leaking is in the arteriovenous phase of the angiogram. So this is in the arteriovenous phase of the angiogram in central serous retinopathy. A leak occurs and the leak becomes progressively increases, and that is called that is the description that you should give while being asked in an exam. This is a smokestack leak, but that is occurring in the arteriovenous phase of the angiogram, and as the angiogram proceeds, the leak increases. This is another patient with the central, you can see a serous detachment here on the fovea. When you do angiogram, again in the arteriovenous phase of the angiogram, the dye is started leaking here. As the angiogram proceeds in the arteriovenous phase of the angiogram, the dye it enlarges, it becomes larger and larger, and even you can see a pooling of the dye in the serous detachment. You can make out there is a hyperfluorescence here. The dye is leaking here. Dye get collected in the fluid in the serous detachment. This is called the ink blot, another feature or another type of serous detachment. So here again a patient with serous detachment in both eyes. When you do angiogram, you are not seeing one leak, you are seeing multiple leaks. This is the CSR with, you can see another CSR, you can see here another focal serous detachment with the leaks here. So here again another serous. See, these are CSRs with multiple leaks. So this type of when you see CSR with multiple leaks, actually you should be very careful. These patients, you have to elicit a history. These patients probably are taking steroids. So look at another. So that is CSR. Look at this patient. Again, this is a middle-aged lady actually presenting with the similar findings in both eyes. You can have a serous detachment here. You can have serous detachment here. This red-free photograph actually showing there is serous detachment here and here. And when you do angiogram, you see multiple leaks here. Again, you look at this. This is not arteriovenous phase of the angiogram. So mind you, a middle-aged lady, bilateral bilateral findings like these, and multiple areas of detachment like these. Presenting with is having a fluorescent angiographic pattern like this, multiple leaks. You see small leaks here. These small leaks appear in the early arteriovenous phase of the angiogram. As the angiogram proceeds, this will become larger like this. Okay, all of them were smaller like this. As the angiogram proceeded, it become larger like this. So it starts in the early arteriovenous phase, it become larger in the mid arteriovenous phase, and in the late arteriovenous phase, you will see the dye getting collected in the serous detachment or pooling of the dye in the serous. So pinpoint leaks becoming larger and get collected in the this area. This is the actually as you can see the collection here. This is a fluorescent angiogram of a patient with PKH. Now, how do you differentiate between multiple pinpoint locks of this and with the CSR? You look at the disc. Disc will be hot in PKH, but won't be hot in CSR. Disc will not be hot in CSR. It will be hot in PKH. And another finding that will help you to differentiate these PKH from CSR is this staining, this pooling of the dye in the serous detachment is very dense in BKH in the late angiogram films, while it won't be so dense in CSR. So that is how we differentiate CSR from BK. Multiple leaks CSR from BKH. Another condition which produces similar findings, serous detachment, multiple pinpoint leaks, is called posterior scleritis. Of course, you will have a clinical evidence. There will be pain for the patient, and you will have only do angiogram. I mean, when you do ultrasound, you will get a T sign. So there are many conditions which will just present with serous detachment. Look at another common thing that is given for your exam, that is actually a branch retinal vein occlusions. You can see hemorrhage here, branch retinal vein occlusion. There is not much use when you do angiogram in this phase of the angiogram, because you will get only blocked fluorescence due to the hemorrhages. So if you want to get a good quality angiogram, wait for some time. You will see the hemorrhages disappear. You see the occluded vessel. Then you see the extensive capillary non-perfusion areas here. You will see the anastomosis of this vessel with the superior vessels. And see this actually, I mean, it can be seen, and you can see it's few microaneurysms. So you can see collaterals, you can see microaneurysms in the CNB areas. You can see new vessels developing. So that is branch retinal vein occlusion. Actually, branch retinal vein occlusion, you should wait for some time for the fluoroglutamate to get a good quality angiogram. So look at this patient. This is a patient with a CRVO. You have injected the dye, and this is a film probably by around 30 seconds. And even by 30 seconds, dye has not come into the vein. By 25 seconds, dye should completely fill the vein, and it has not come. So there's a delay in the filling of the vein, and you can see the cystoid flower petal appearance of the dye leakage here. So cystoid edema. This is a non-ischemic CRVO because there are no capillary non-perfusion areas seen. So this is a non-ischemic CRVO with the CME. Now, look at this picture. This is a CRVO, but you see the angiogram, extensive CNB areas, which is more than 10 disc diameter. So this is an ischemic CRVO, extensive CNB areas. Now, another common fluorescent angiogram that will be kept for you is the choroidal neovascular membrane. As you see, this is a patient who had presented with a reduced vision, maybe around 6/60. You can see a grayish membrane, hemorrhage here. When you do angiogram, you see this is an early angiogram. Dye has just come into the artery, but not in the vein. Even in the choroidal phase, you see a lacy filling. You can see a lacy filling. This is in the early phase. As the angiogram proceeds, now the early arteriovenous phase, it becomes more prominent. As in the late phase of the angiogram, you see the dye, there is leakage and the margins become fuzzy. So early appearance in the choroidal phase or early arteriovenous phase, and the dye and it becomes, the margins become fuzzy and become larger, and that is the classic CNV. You know, choroidal neovascular membrane occurs as the choreocapillaries, which actually breaks the Brooks membrane. So the defect in the Brooks membrane, the choreocapillaries along with fibroblasts come into the sub RP space, producing your type 1 CNVM, and then it comes into the subretinally producing the type 2 CNVM. This classic and occult CNVM is actually angiographic classification. So classic CNVM, early appearance, even the choroidal phase, and the margins become fuzzy as the angiogram proceeds. But look at this angiogram. This here you can see a small elevation of the retina or irregular, yellowish, deep pigmented area. When you do angiogram, you see the angiogram, these type of stipple granular fluorescence occurring only by around 1 to 2 minutes. But in classic CNVM, very early, by 10 to 15 seconds, this will appear. But in occult CNVM, actually, there is a stipple hyperfluorescence, which will appear only by 1 to 2 minutes after the injection. And it will not be, as the angiogram proceeds, it will leak, but it will not be so dense as in classic CNVM. So the angiogram, the leak will appear only after around 1 to 2 minutes. And this is actually an area of elevated RP with some, neovascular tissue underneath. So this, when you do OCT, you will get you see the elevation of the RP, you see the neovascular tissue there. So this is occult CNVM, and this is a pigment epithelial detachment. So this is called a fibrovascular PED, one type of occult CNVM. The other type of occult CNVM is called a late leak of undetermined source. Here, when you do angiogram, you will not see any leak till 1 or 2 minutes. You will see the angiogram leak in the late phase of the angiogram. So that is classic, very early in the choroidal phase, late by, the occult CNVM of fibrovascular PED by 2 minutes around after the injection. Then this will be, even after 2 minutes, there will be late leak. This is called late leak of undetermined source. So that is the angiographic classification. It's classic, occult, two types. That is, occult is PED, fibrovascular PED, and late leakage of undetermined source. Now, look at this particular part. So this is not that important. See, you see there is an occult CNVM here, stipple appearance of the angiogram, but there in the center of it, you see a classic CNVM. So it's a classic CNVM inside this entire part of the CNVM. This classic CNVM occupying more than 50% of the entire lesion. So this is actually a predominantly classic CNVM. It's both classic and occult, but it's predominantly classic. But look at this. Again, and stipple fluorescence. So this is actually an occult CNVM, but in the center there is a classic CNVM. So this is actually occupying, this classic CNVM is occupying less than 50%. So this is minimally classic CNVM. This is no longer valid because previously when you used to treat these patients with PDT, patients with predominantly classic CNVMs are better responders to PDT. So this classification is no longer now used because all of these patients we are treating with we are actually treating with anti-VEGF agent, so it's not that important. So, but you may be asked, what is a predominantly classic CNVM or a minimally classic CNVM? So this is an online patient who had a scar on the fovea, and he had a vision of around 5/60, and he had some hemorrhages here. So you want to know whether this is actually the active or just a scar. You do angiogram, you can see a scar here. Actually, you can see a scar here. You see, look at the scar. The scar is getting, hyperfluorescent. That is expected. You can think this is a staining of this. But when you see in the late phase angiogram, around this scar, there is leakage of the dye. So there is activity, and you have to inject these patients. So that is actually CNVM scar with activity. So these are the common ones that you asked: diabetic maculopathy, PDR, then central serous retinopathy, then CNVMs, and classic and occult CNVMs. These are the common angiograms kept for any of these exams, MS, DNB, or FRCS exam. But look at this. This is I am not giving so much of importance to this, but this just I want to give you an idea. This is a lesion where you see an area. You can see a small hemorrhage here. You can see a vessel dipping there. You are seeing probably an elevated retina here, an exudates here. So you know there is exudate, there is a vessel going there, probably a vascular disease. So actually this is called retinal angiomatous proliferation. Very, very significant finding. Actually this very, very important clinical finding. You look at these hemorrhages and a vessel dipping there. This is retinal angiomatous proliferation. I told you choroidal neovascular occurs in the choroid and coming to the retina. Here this neovascular is occurring on the retina. That is, first stage is intraretinal. Next, it will go down into the subretinal space, that is stage 2. Then it enters into the choroid, that is stage 3, retinal angiomatous proliferation. Very important clinical suspicion is necessary to diagnose this, but this hemorrhage will give you clue, the vessel dipping there, some exudation. So this is a textbook photograph showing, of a patient with a retinal angiomatous proliferation, 2 hemorrhages and seen here. And when you look at the angiogram, a vessel dipping there. So the fluorescent angiogram can make you suspicious of the retinal angiomatous proliferation. There is leakage of the dye here. Okay, so you are suspicious because of this hemorrhage. And when you do ICG angiogram, if there is a choroidal neovascular membrane, you can see actually a hot spot. And actually OCT will give you an evidence that there is a pigment epithelial detachment. In stage 2 retinal angiomatous proliferation, when it reaches from the retina to the subretinal level, there is pigment epithelial detachment occurs. then so you can actually put all these multimodal imaging to find out retinal angiomatous proliferation. But this clinical suspicion is very, very important to make a diagnosis probably. So the retinal angiomatous proliferation is a reverse process that occurs in the retina to the cornea. Okay. So I think I have gone through the common questions on the fluorescent angiogram, that is on on diabetic retinopathy, then on central serous retinopathy, then on choroidal neovascular membrane. These are the common ones that is kept for any exam. Now look at this. This is again a common station for you for any of these exams. So that is interpretation of optical coherence tomography. So our discussion is primarily on the cross-sectional OCT, where you take cross-section of the OCT, the retina, and interpret it. In cross-sectional OCT, we can actually see individual layers, and we can find out the abnormality of the individual layers. This is actually the 10 layers of the retina, from the retinal pigment epithelium to the internal limiting membrane. This is a schematic representation of this. And this is actually the OCT representation. Actually, you know, the OCT can can depict up each layers that is seen on histogram. We were actually using different types of OCT. From this is an old version called the time domain OCT. Then we have spectral domain OCT, which is widely used now, and the very advanced subsource OCT. From these pictures itself, we can see that resolution is much higher in the subsource OCT. But majority of us using the spectral domain OCT. And we are using this machine made by the Heidelberg, that is a spectralis OCT. So the pictures that I'm going to show you are actually on the spectralis OCT. So when there are so many scan protocols when you open the machine, which will be used? That is the first doubt that we have. So the most commonly or the most useful ones are the one called the 3D protocol. This is some machines in the Zeiss Cirrus machine and all you can see as the macular cube. So it is the 3D protocol. Here actually you are scanning in a rectangular area. You are scanning the macula. So this information is very, very important to generate complex statistical analysis so that you can get thickness maps, volume maps, all because of this 3D analysis. But another very useful one which you use is the raster. 6 or 7 lines scatter raster, or even up to 24 lines or 28 lines are now available in various machines. These are all line scans going through the fovea. Okay. Or the area of interest. You can bring it to any of your, suppose if it is lesion is here, you can bring this scan here, any of these. So this is the raster scan. Another commonly used is the radial scan. Here you have actually 6 to 12 lines or even more, which are radiating from any common axis. What is the advantage? If it is centered over the fovea, then you can, the radial scan is centered over the fovea, then you can see the location, relation of this lesion. Suppose the lesion is here, you can relate the lesion to the fovea. So these common ones are the 3D or the 3D scan, the radial scan, and the raster scan. See, very, very important is this 3D scan. You can get thickness maps, volume maps only through this. So you have all these layers of the retina. You can see the retinal pigment epithelium from here. You can see the retinal pigment epithelium here, but I will just go from the front. You can see the internal limiting membrane, the nerve fiber layer here, the ganglion cell layer here, and you can see the inner plexiform layer. Then you can see the inner nuclear layer, the outer plexiform layer, the outer nuclear layer, and you can see here another hyperreflective structure, that is the external limiting membrane. Then you can see this line which is marked here. If you look at here, it is marked as inner segment, outer segment junction, the photoreceptors. So these were actually the original understanding, but now the international nomenclature has come, and actually what has happened is this layer, which is actually the ISOS, inner segment outer segment junction, is now called as the ellipsoid zone of the photoreceptor. You can see this is now marked as the ellipsoid zone of the photoreceptor. But just above it, and below the external limiting membrane, there this myoid zone. And below it, actually, I mean, peripheral to the ellipsoid zone, you see again another hypo area, that is actually the outer segment of the photoreceptors. And this RP itself, if you look at carefully, it is divided into 2 areas. The first is actually the interdigitation zone, and this is the RP. So interdigitation zone is actually where the photoreceptor outer segments are actually mingling, interdigitate with the microvilli, that is this layer. And the ellipsoid zone here is actually from the outer segment of the photoreceptors. Actually, you see the area where there's a lot of mitochondria, a lot of energy production occurring. That area is seen as the ellipsoid zone. And here, actually, the myoid zone of the photoreceptors, or the inner segment of the photoreceptors, is seen as the myoid zone, where there is actually where there is protein production. So simply understand the ellipsoid zone is different from the ISOS junction. So as of now, it is you look at the outer area here, you are seeing the external limiting membrane. Next hyperreflective band is the ellipsoid zone. Next hyperreflective band is actually the interdigitation zone, and next is the arc. Okay, so that has come now based on the international classification. There are 18 layers of the retina has been described, starting from the precortical vitreous, ending with the corridoscleral junction of the corridoscleral junction. So that is it. So usually an OCT picture will be given to you, and the examiner will ask you, oh, can you identify whether this is the right eye or the left eye of this patient? Just look at this photograph. Actually, you are seeing this is the fovea and this is the optic disc. Look at the angiogram. The scan is going from here to here. So this particular part is optic disc, and this is the fovea. And you can see the hyperreflective band, that is the papillomacular bundle of the nerve fiber layer, which comes towards the disc. So we can clearly say this is the OCT or picture of a patient of patient's left eye of the patient, because you are seeing the disc here, the macula here, and this papillomacular bundle. This is the left eye of the patient. So now it's the scan, vertical scan or horizontal scan. You again look at this. You can see this mark here. This scan is going from the disc to the macula. So this can say this is a horizontal scan. Look at this. The scan is going from here upwards. So this is a vertical scan. So the examiner may ask you, which is this right eye or the left eye, or maybe the horizontal or a vertical scan. And in the normal OCT macula, you are seeing a small depression. This is a foveal depression and a hyperreflective spot on the center. This is again normal. And you can see, very important, look at this. To know whether your fovea is normal, you look at the nerve fiber layer. It is ending on the fovea. Look at the outer plexiform layer. It is ending there. Okay. So when the outer plexiform layer and the nerve fiber layer meets, and the fovea is actually fovea. So you see some little bit of small hourglass-like structures here. This is actually the blood vessels. The blood vessels will cast shadows on the entire section of the OCT. You can see the shadowing by the blood. Hourglass-like structures will casting shadow. So actually this is the vessel casting shadow. So all these are normal findings. So when somebody has given you angiogram and the OCT, and then asking you whether this has got whether this has got a foveal section, I told you to understand fovea to OCT whether this is foveal cut or not. You have to just trace the outer plexiform layer and the nerve fiber layer. It should meet. Okay. Now look at here. It is not meeting. Look at here. This is actually, you see. Here, the outer plexiform and nerve fiber layer meeting. There is something abnormal there, so some structures there, but this is a foveal cut. But look at here, there is something abnormal here. You see the outer plexiform layer is continuous here, the nerve fiber layer is continuous here. So this is not a fovea. You can see, or similarly, when you come little down, you actually see the outer plexiform layer is continuous here over the fovea, and here again it is continuous. So it is not a fovea. You can tell this is a fovea. These are not the foveal cuts. So usually when you start seeing OCT pictures, the residents will come with whether, sir, this is something abnormal or not. This is called a foveal bulge, small foveal bulge. Actually, below the ellipsoid zone, this is actually normal because the long outer segment of the photoreceptor is actually causing this. This is normal. And you can see it's look at this. You see the normal OCT has got the inner retina has got an M profile like this, but the outer retina has got a mild concave profile. But this, look at this. This is not mild. This is something very gross, and you can even say this is a very large eyeball. This is of myopia. This is actually a staphyloma. So even the refractive error can be found out. So before interpreting these, you have to just understand whether these are very good quality images or not. See, these are, you look at this, you cannot differentiate the layers very well. This may be many causes for this. There may be media opacities or many causes. So this is a poor quality image. Look at this, the lower part of the angiogram is not, the OCT is not visible. The upper part may be cut in some cases. So these are truncated images, which are also not good. And you can, if you look at this, you see a number called Q16 here. Actually, this says whether this is a good quality image. Whenever you start using this, the OCT scans, whenever this falls below 15, when you do the case, you will see a red light there. That means the quality of this angiogram OCT is not good. So this number indicates anything more than 50 as 15 is very good. So that is on the quality of the images. No, to understand again this OCT is actually, in angiogram it is hyper and hyperfluorescence, but in here it is defined in terms of the reflection of light or the transmission of light. Reflection may be hyperreflection or hyporeflection. Shadowing, transmission of light may be hypotransmission or hypertransmission. Look at this. You look at this. Actually, here you are seeing something in the OCT scan. They are hyperreflective structures. This is reflection. Look at this. There are something hyporeflective. Okay, this is transmit. One is hyperreflective, one is hyporeflective. Look at this again here. This is, and so it can be hyperreflection or hyporeflection. But in this can be hypotransmission or hypertransmission. Look at this. There is some some bleeding here on the retinal surface, actually, which is producing shadows, or it is not allowing the light to go inside. That is hypotransmission. But here you see the retinal pigment epithelium is gone. It allows the entire light, damage here, so that the entire light is going very well into the choroid, not here where there is RP. So this is hypertransmission. So hyperreflection, this reflection may be actually hyper or hypo, and transmission may be hypotransmission or hypertransmission. So we are going to look at these pictures. What is being asked in another 10 minutes time on these diseases as diseases affecting the vitreoretinal interface, inner retina, outer retina, subretinal, and the choroid. So this is actually a fluorescent angiogram. You can see this, the OCT picture where you see the posterior hyaloid is separated from here, but it is attached onto the fovea. So here the posterior hyaloid is attached onto the fovea, but it is separated from the perifoveal area. So it is attached on the fovea. So this is called, there is no structural alterations on the fovea, it is just attached. So this is called vitreomacular adhesion. Vitreomacular adhesion is the separated the posterior vitreous phase, which separates from the perifoveal area, but attached to around within 3,000 microns from the center of the fovea, but no structural alterations. But look at here. It is again detached, but it is producing some structural alterations here. See again here, it is pulling. So this is vitreomacular traction. This is vitreomacular adhesion. In vitreomacular adhesion is attached, but no structural alteration. In vitreomacular traction, it is attached, but with definite structural alterations. So that is vitreomacular adhesion and vitreomacular traction. So now you look at this. Another vitreomacular interface disorder is epiretinal membrane. You see a hyperreflective lesion on the surface of the retina. So this is epiretinal membrane. Normally you see this foveal depression should be here, and the outer plexiform layer and the nerve fiber layer should meet here. But here you are seeing everything is pulled toward the center. This is because of this epiretinal membrane pulling. You are not expecting all structures to come like this, but this is because of the epiretinal membrane pulling it. But look at here, again a hyperreflective band. This is epiretinal membrane. The pulling is evidenced by this particular fact. See, the retinal tissue is going up like this. This means there is traction by the epiretinal membrane. You can even see the detached posterior hyaloid is here, but it is attached to this membrane here. Okay, so this is epiretinal membrane, a hyperreflective structure on the surface of the retina. So another important use for OCT is to look at macular hole. See, you can see there is, look at this structure here. There is maybe a cystic change in the inner retina. Actually, the posterior hyaloid is pulling there, producing structural alteration. This is here. This probably is a stage 1 hole, stage 1A hole. Look at this. This defect is now centrifugally spreading to the retinal pigment epithelium. See, the same thing is happening there, but this defect is spreading centrifugally here. This is stage 1B macular hole. But here you can see it has come off, and the posterior hyaloid is attached on one edge of this area of this hole. So this is stage 2 hole. Mind you, very careful, this detached posterior hyaloid, partially detached posterior hyaloid is attached onto one edge of the hole, and is an eccentric separation of the hole. So this is stage 2 hole. Here you see the hole is there. There is a full thickness macular hole, but the posterior vitreous is now separated from the edge of the hole. This is stage 3 hole. Stage 2, the posterior hyaloid is attached to one edge, eccentric. Here it is separated from the edge of the hole. This is stage 3 hole. This posterior hyaloid separation, if it extends, if it is separated from the disc also, then it is called the stage 4 hole. So in macular hole, you can just make a diagnosis of this macular hole. Staging of macular holes can be done. You can also classify the macular holes, and you can tell patient this is your defect. So OCT may be useful to educate the patient also. Another important problem that you face is this differentiation between lamellar hole and pseudo hole. Look at this picture. Here you can see there is a epiretinal membrane. Can you see epiretinal membrane here? It is pulling the retina up. Look at this between the inner retina and outer retina. Outer retina. Inner retina is anything tissues up to the outer plexiform layer. The tissues beyond the outer nuclear layer and the photoreceptor layer and the retina, the retinal pigment epithelium is taken as the outer retina. Inner retina is up to the outer plexiform layer. So there's a cleavage in the inner retinal layers. You can see a cleavage. So this is actually a lamellar hole. Now here again you see there is a cleavage into the inner retina. So this is a lamellar. Look at this. Here again there is some loss of the inner retina. Can you make out? There is some loss of the inner retina here. So this is an excavation into the inner retina, but the outer retina remains same, normal. Okay. So this is another type of lamellar hole. Here is a cleavage that is going into this, but this is actually an excavation going into the inner retina. So this is an atrophic lamellar hole. This is a tractional macular hole because these epiretinal membrane is pulling there, and probably that is pleasing. But look at this. This is a pseudo hole. Actually, there may be an epiretinal membrane. You look at this, there is no excavation, but all the retinal layers are seen there. There is no excavation, and the patient has got excellent vision in this. So this is a pseudo hole. So if there is a cleavage, it's very easy to detect that it is a lamellar hole. So you can differentiate lamellar hole from pseudo hole. Now we will look at structures which produces inner retinal hyperreflectivity. So inner retinal hyperreflectivity may be due to the cyst in the inner retina. You see cyst in the inner retina. Okay. So these are collection of fluid in the inner retina. Actually, this symmetrical collection. So when you see such symmetrical cyst on either side, is actually of cystoid macular edema, especially in cases of in post-operative cystoid macular edema, where you see symmetrically on either side of the center of the fovea. But if you see cysts like this on either side, not symmetrical, that is more of diabetic. So this is the hyperreflectivity of cystoid macular edema, inner retinal hyperreflectivity. Another cause for the inner retinal hyperreflectivity is actually the schisis. You can see the inner retinal layers are splitted, like here in a patient with a chronic CSR, or in a patient with juvenile retinoschisis, inner layers are splitted like this. Here it is actually cyst collection. But look at this, another cause of inner retinal hyperreflectivity. This is actually, you can see the inner retina is damaged here actually, and only the ILM is hanging there. The ILM is draped here, and this is a early stage of actually the macula or the parafoveal telangiectasia. So this chain is called the ILM draping in macula. So inner retinal hyperreflectivity may be CME, or maybe schisis, or maybe macula, which is producing this. So inner retinal hyperreflectivity, when we talk about this, we have to see that there is something called diabetic macular edema. So you have, this is a cystoid macular edema. This here there are no cysts, but the retina is edemated. This is a spongy edema, but here you can see the posterior hyaloid is pulling the fovea and producing edema in a patient with a diabetic macular edema. You are seeing exudates here actually. You can see hard exudates. You can see hard exudates here. You know, hard exudates are up to the in the outer plexiform layer. You are seeing it in the outer plexiform layer. So this is cystoid macular edema. This is spongiform edema. This is fractional edema. Here again, there is hard exudates. So any of these may be associated with the serous macular detachment. So these are the types of diabetic macular edema. So inner retinal hyperreflectivity is, as we are actually now talking on inner retinal hyperreflectivity, now we are talking on inner retinal hyperreflectivity. Inner retinal hyperreflectivity can be either due to ischemia or maybe inflammation or maybe hard exudate. Look at this. Look at this patient. This patient is having inner retina up to outer plexiform layer is here. You are having hyperreflectivity here. Actually, these are a large cotton wool spot. You know, by definition, cotton wool spots are large, extensive infarcts of the nerve fiber layer and adjoining retina. You can see here, this patient subsequently recovers. This regresses, and you can see this side of the retina is normal, but the area where cotton wool spot has regressed, there is atrophy of the inner retina. Look at this patient. This patient is having central retinal artery occlusion. See, the inner retina out up to the outer plexiform layer is actually hyperreflective. This patient, when it comes, initially you can have cherry red spot, you can diagnose it very well, and so you can diagnose it very well because cherry red spot is there. But when you do take OCT, you will see the inner retina is totally, hyperreflectivity is there. But a patient comes to you maybe after 2 weeks time, the cherry red spot may not be so evident. But when you take OCT, you will see this hyperreflectivity is persisting. So this will give you excellent clinical, excellent idea whether that was a CRI or not. Because after 2 weeks, the reperfusion may, little bit reperfusion may occur, cloudy ceiling will reduce, your cherry red spot may disappear, but this OCT finding may not disappear by till around 1 month. So the hyperreflectivity up to the outer plexiform layer, because the central retinal artery supplies up to the outer plexiform layer. Now we look at this patient here, inner retinal hyperreflectivity, but from the disc to the fovea, macula, certain area of normal retina. This is central retinal artery occlusion with its persistent ciliaretinal artery. You will get excellent idea from the OCT. Look at this, 1/2 is involved, inner retinal hyperreflectivity 1/2, but other half is normal. This is a branch retinal artery occlusion. So in central retinal artery occlusion, there is hyperreflectivity up to the inner retina. Up to the outer plexiform layer. This will go for atrophy after probably around 1 month time. So the inner retina get atrophied in the atrophy, and this thickness reduces. But initially, up to around 1 month, you can detect this hyperreflectivity, and that will be up to outer plexiform layer. Look at this condition. So this is cotton wool spot, CRIO versus CRIO, person ciliaretinal artery, BRIO. Look at this. This patient is a patient complaining of sudden scotomas on one side, fundus on central scotoma. When you take for fundus, fundus, you will not see much findings. But when you see these, OCT, you will see there is hyperreflectivity in the inner retina, and it is limited by the outer plexiform layer, and it is in the middle part of the inner retina. Okay, acute scotoma, so it is called paracentral acute middle maculopathy. It is on the middle. So this is total inner retina, this is middle inner retina, but limited by the outer plexiform layer. So look at another patient complaining of sudden, this is actually due to ischemia of the deep capillary plexus. Another patient complaining of sudden scotoma, central scotoma. When you see, this is the outer plexiform layer. OCT will show you hyperreflectivity, actually peripheral, or posterior to the outer plexiform layer. This is up to outer plexiform layer. This is up to outer plexiform layer, but limited in the center part. So it is paracentral acute middle maculopathy. But this is beyond the outer plexiform layer, actually in the outer retina. So again, a hyperreflectivity. I included it here because this will make you remember everything together. This is actually the acute macular neuronal. Again, patient will present with the scotoma. So another cause of inner retinal hyperreflectivity is retinitis. You see, this is a toxoplasma retinitis, again inner retinal hyperreflectivity. So another cause, I already told you, inner retinal hyperreflectivity is seen in hard exudates, which is seen in the outer plexiform layer, which may produce cast shadows. So these actually are hard exudates. And look at the size. You look at the size of these lesions here. These hard exudates are actually, they are of a size of more than 40 to 50 microns. But look at these small spots. These are actually hyperreflective spots. So you have to differentiate this hard exudate from these hyperreflective spots. These hyperreflective spots may be present in patients with diabetic macular edema. Whenever these hyperreflective spots are there, which is not hard exudates, this may be usually seen in the outer plexiform layer, but may be distributed through the entire retina. So when they are there, it suggests an inflammatory reaction, inflammatory role for this diabetic macular edema, and your intravitreal dexamethasone may be more useful than anti-VEGF agents in treating. So these are called hyperreflective dots or hyperreflective spots, but these are hyperreflective. These hyperreflective lesions, which are larger than 50 millimeters, 50 microns, are actually hard exudate, but these are called hyperreflective spots. Hyperreflective spots are suggestive of inflammatory etiology for your diabetic macular edema. So dexamethasone may be of more use. It may be distributed through the entire retina. Another thing of importance in diabetic macular edema affecting inner retina is actually the drill. Drill is disorganization of the retinal inner layers. You cannot see the layers, the differentiation between the layers. You cannot see the layers in this OCT. So this is drill. Drill is actually very important OCT biomarker for diabetic maculopathy. When drill is present, patient is an indicator of poor visual prognosis. Actually, suppose it is actually measured in the linear, in the horizontal extent in millimeters around the fovea. Suppose if the drill extends by around 3 millimeters, 300 microns, around 300 microns from the pre-existing level, there will be a drop in visual acuity by 1 line. So drill indicates a poor visual acuity. Actually, you cannot differentiate the layers of the inner retina. That is drill, another OCT biomarker. That is about inner retina. In another 5 minutes, I will take, I think, we will be talking on the outer retina. Outer retinal hyporeflectivity are actually outer retinal tubulations, mactal advanced stages, and solar retinopathy. Look at this patient. This is actually, I showed you the initial inner retinal hyporeflectivity as mactal. Now in the advanced stages, outer retina also gets damaged. Actually, the ellipsoid zone, the external limiting membrane, and the outer retina itself gets damaged. So outer retinal hyporeflectivity may be seen in cases of even the outer nuclear layer is I told you, from the outer nuclear layer to the periphery, towards the RPE is actually the outer retina. Actually, this is gone in outer retinal hyporeflectivity is occurring in advanced mactal. Look at this patient. You are actually seeing some round structures here. They are hyporeflective. They are seen in the outer nuclear layer. Mind you, they are seen in the outer nuclear layer. They are seen in areas where there is no RP or RP is damaged. This suggests very advanced diseases. Actually, where there is loss of retinal pigment epithelium, there is loss of photoreceptor. What you see as round here is actually the photoreceptors arranged here. And these are not cysts. You should not inject intravitreal. You should not give intravitreal injection thinking that they're cysts. Actually, this is an evidence that the disease cannot be cured, and actually you need not inject. These are actually not cysts. Actually, the photoreceptors are arranged like in a circular fashion. So the cyst may be hypofluorescent centrally, and the surrounding or the margin of the cyst is not is not having that ring-like fashion hyperreflectivity. Actually, the cyst will have uniform hyperreflectivity, but here you can see even in the center you will see a speck of hyperreflectivity. So these are outer retinal tubulation. They are seen only in the outer retina, but your cyst is seen in the inner retina. But your outer retinal tubulation is seen in the outer nuclear layer. Cysts are the inner retina. So you can differentiate it. So the presence of outer retinal tubulation means you stop injections. Another patient you see, look at this. So this outer mactal advanced stages and outer retinal tubulations. These are seen in many diseases, any degenerative diseases, seen in age-related macular degeneration, etc. But look at this patient. This patient is looking at the habit of looking at the sun. You see some yellowish spots here, and on acute phase you will see hyperreflectivity from the fovea to the RP, from the ILM to the RP. But as later you will see there is a permanent defect in the ellipsoid zone and in the RP. So this is solar retinopathy. So outer retinal hyperreflectivity may be mactal, maybe outer retinal tubulations, or maybe solar. So look at this, another common condition that comes to you, patients taking chloroquine for more than 2 years on their regular dose, for example 6 mg per kg per day. These patients will develop, probably some can develop chloroquine toxicity by around 2 years, but that is rare. Only 1% of this population will develop chloroquine toxicity. The important findings of this chloroquine structural damage in OCT is seen even before your clinical fundus appearance. So what you have to see is actually look at this OCT picture. These structural changes occurs even before your fundus appearance. You see the external limiting membrane, the ellipsoid zone cannot be traced into this particular area. So there is even the outer nuclear layer has been damaged. So actually in the parafoveal region, there is thinning of the outer nuclear layer. Loss of ellipsoid zone, loss of the external limiting membrane occurs on this area. And this area will become thin and even RP get damaged. So what will happen? This area, this inner retina is inner retina will come little posteriorly. And so there is an apparent bulging of the fovea because the fovea has got an excellent resistance in chloroquine toxicity. In the fovea, you see external limiting membrane, the ISO, the ellipsoid zone, and the RP is remaining normal. So the parafoveal the inner retina comes a little backward, and so there will be a forward bulge here. This sign is called actually the flying saucer sign in chloroquine toxicity. So you can see subretinal hyperreflectivity lesions. So subretinal hyperreflectivity is anything below the ellipsoid zone. You see here below the ellipsoid zone, above the RP, there is some this is a CNVM. Here again, you see below the retinal pigment epithelium, above the retinal pigment epithelium and the ellipsoid zone, you see some hyperreflectivity. This is a CNVM. But this is of amorphous nature and is actually having heterogeneous nature. So that means there is reflectivity. I mean, that means there is activity, and you can see there is some subretinal fluid. But here you can see there is homogeneous, reflectivity actually. So this is a scar. So other causes for subretinal hyperreflectivity may be fibrin of CSR, inflammatory cells of the leakage. You can see multifocal detachment here, inflammatory cells here, or subretinal lipofuscin-like material in the below the RP, that is in a disease called adult vitelliform degeneration or Best disease. And here you can see on either side of the PED, you can see hyperreflectivity. So the subretinal hyperreflective may be CNVM or a scar, or maybe blood, or maybe fibrin, or maybe inflammatory exudates. Hyperreflectivity may be the serous detachment. When you see this serous detachment like this, you don't jump in and make a conclusion that this is a serous detachment. This may CSR, it may not be CSR. It may be a pit that is leaking, producing a CSR-like finding, or maybe a peripheral, lesion that may be leaking fluid. So you cannot jump into conclusion that this is a CSR. You have to have a fluorescent angiogram to look at it. Another cause of hyperreflectivity is actually the detachment. You see the vertical scan, there is a detachment coming up to the fovea, there is inferior retinal detachment or a tractional retinal detachment producing subretinal hyperreflectivity. So this is the lesion in the Brooks. These are lesions, common lesions, Brooks complex, Brooks RP complex or PEDs. This is a drusenoid PD, this is a serous PD, hemorrhagic PD, and this is a fibrovascular PD. How do you differentiate this? You can see the bumpy RP, you can see hyperreflectivity beneath this. This is a drusenoid PED, but here the serous PED, because the light is allowed to continue into the choroid. So this is serous PED, but here it is blocking the choroidal fluorescence. So that, choroidal view actually, so something blocking here. So this is a hemorrhagic PED. This is a fibrovascular PED. Actually, you can see a heterogeneous nature of hyperreflectivity beneath the PED. So that is Brooks. So you can also get PEDs in the disease called PCV, where you see actually the tall peak PED, or actually the notch PED or thumb-like PED. Or this is very important. This is a double layer signing PED. This is shallow PEDs where the pigment epithelial detachment occurs. You see the line of the pigment epithelial detachment and the line of the Brooks membrane. So this is a double layer sign, again PED. So this is a normal choroid. Normal choroid is having the thickness of the almost same as the retinal thickness. You can see all the layers: the retinal capillary, the choroid capillary, the smaller layer, saltless layer, and the Hall's larger capillaries. In a disease called thin choroid is seen in myopia, while thick choroid in a series called pachychoroidal disease, where you see large vessels like these. Some alterations in the retinal pigment epithelium, that is called pigment epitheliopathy. When you have large pachy vessels with fluid, then it is called central serous retinopathy. You have double layer sign with fluid, that is pachychoroidal neovasculopathy. But when you see notch PED is fluid, then PCV. But to differentiate these, actually you require ICG angiogram. ICG will show polyp here, but only neovascular complex in pachychoroidal neovasculopathy. So I think I will stop with this qualitative analysis, but because there are quantitative analysis are there, which is, I think, because the time constraint, we will stop it. And generally, qualitative analysis is asked for the exam. Thank you.
Yeah, thank you, sir, very much for that wonderful and nice lucid talk. It was very much informative, and I hope all our PGs must have benefited from that talk. So there are a few questions, sir, in the chat box, which I would like to ask.
Yeah.
Which OCT scan protocol to select in each case, and how we can decide on that?
So there are innumerable protocols, but most useful ones are actually if you want to take macular thickness, actually macular thickness map. For example, in diabetic maculopathy, actually that was the next part of that lecture actually. So what happened is you have to take 3D maps, 3D protocols. Then only you can take volume maps or thickness maps. But generally, otherwise you have to use a raster scan or a radial scan. This will give you very good information.
Sir, another question in the chat box is what are important OCT biomarkers?
So OCT biomarkers for are different for different disease. For example, for diabetic retinopathy, there are so many biomarkers. Like I have already told you that a drill or actually hyperreflective spots or serous, subretinal, serous detachment of the fovea. So actually, presence of drill or the hyperreflective spots actually they represent poor prognosis. But absence of, serous macular detachment, absence of hyperreflective spots, and the attached posterior hyaloid, they represent very good prognosis for actually the diabetic macular edema. For age-related macular degeneration, your outer retinal tubulations, you have PEDs, all these are taken as important biomarkers.
Okay, sir, I would like to ask you, sir, when there is a new fresh case of an active CNVM, how would you like to proceed? Do you do FFA and OCT both, or what is the protocol followed?
Yeah, generally, when the patient comes, we will do an OCT so that we will get an idea. And then, of course, definitely angiogram we will definitely do in these cases. And if you have
In
a suspicion,
all the cases.
yes, if it's a PCV, if you are clinically and your OCT is telling you that it is PCV, then ICG also will be done. Generally, we will do FFA alone only in diabetic retinopathy and CSRs, but otherwise, any choroidal lesions, we will combine it with ICG.
Okay, sir, and about monitoring response of anti-VEGF in case of AMD.
That situation, we will in monitoring the response and follow-up, we will generally use OCT.
OCT alone.
Yeah.
Okay, sir.
Unless you see that recurrence, or then you will probably again do angiogram. Otherwise, only OCT.
Okay, sir. So could you elaborate on the little bit on the newer OCT for benefit of PGs, EDI and swept source?
See this, you can see that this your old status OCT could not image the choroid very well, but in the SD OCTs you have an option called the EDA OCT. This will actually can image your choroid well. But now you have the subsource OCT, which actually uses a different light source around 10-50 nanometer, which have excellent penetration, so it can actually image the choroid very well. Subsource OCT, the resolution also is much better.
Sir, what is your opinion on ultra wide field angiography in diabetic retinopathy as such?
Yeah, see, there are cases where the wide field angiogram actually will give you more insights. Actually, we can see extensive. There are findings, a typical diabetic retinopathy findings will be there in these like peripheral ischemia. All these can be picked up very well with the wide field angiogram.
Sir, just I wanted to know whether you are using your test doses given before angiogram at RIO.
Yeah, we are giving.
Test dose is given, sir.
Yeah, it's given.
And okay, and is the angiogram done in presence of anesthetist or physician fitness is taken before doing angiogram?
Yeah, every patient will have a physician fitness, that is for sure. But anesthetist will be available in the hospital, but we have to be, he will come on call. He will come in 2 minutes time, or he or she will come in 10 minutes time, but he will be available. And he may not come to you to the angiogram room as such.
Okay, sir. Sir, whether the test dose is intradermal or subcute,
Yeah,
or
we give it. Here actually we give intradermal.
Intradermal, just before the FA.
Yeah.
Okay. So there's one question in the chat box: how to differentiate a CNV and pachychoroid neovasculopathy on OCT?
See, pachycaudal neovasculopathy, the slide is already there. You see, pachycaudal neovasculopathy is actually where you see you see a elongated PD, shallow PD actually, and you have the double layer sign. This actually favors a pachycaudal disease rather than an age-related macular degeneration. So ICG angiogram may be necessary in these cases to look for polyp. Actually, such a long double layer sign is actually favoring more of a pachycaudal disease.
Sir, and what is the role of like angiogram in uveitic patients? What particular uveitis cases would you take up for angiogram?
See, definitely we will do angiogram, especially in all. I mean, posterior uveitis, especially the common one is actually your VKH. These patients we will do angiogram. Traditional teaching is this VKH is there in bilateral middle-aged ladies, but we see a lot of VKH cases in young patients. We see unilateral cases. Angiogram will give you typical fluorescent angiographic patterns, pinpoint leaks, fluorescent pooling dye, and will definitely these patients will undergo ICG also for us, because you can see that when you do ICG angiogram, you will pick up these lesions. The number of lesions, these granulomas are much more than what you see with the fluorescent angiogram. So common UAT case that we do go for angiogram is our VKH. And then intermediate UAT patients going for cystoid macular, all these cases will go for fluorescent angiogram. Not always, but the VKH cases definitely will go. Toxoplasma cases will go for angiogram, especially when you are suspicious of a CNVM developing.
Secondary CNVM.
Yeah, secondary CNVM.
There is one question in the chat box. Difference in FFA picture in VKH and serpiginous choroiditis, is that?
Yeah,
sympathetic ophthalmia. Sympathetic ophthalmia.
Yeah,
okay,
that is definitely sympathetic ophthalmia. That history will be. See, you have to understand. No investigation can be interpreted with the investigation alone. It has to have a clinical correlation with your fundus finding. So most important is clinical findings. So I just want to tell you again this. You are seeing a lot of our residents also seeing a lot of cystoid macular patient. Every patient is in for OCT. But actually, whether it is necessary or not, I don't know, because you have an evidence, clinical evidence is there. Similarly, in what you have this your sympathetic ophthalmic case, you will have a history. No, you will have a history. You will have the evidence of the history of injury to this patient. Fluorescent angiogram again will have this type of similar leaks will be there, but the history will actually help you. And it will be a unilateral disease. This will be actually a bilateral disease. I mean, majority of cases. So clinical history, clinical examination is definitely more important than your investigations.
Yes, sir, definitely. Sir, one more question is there in the chat box. Is there any role of fluorescent angiogram in disc edema to differentiate between inflammatory and ischemic cause?
Yeah, see, you cannot actually, both of them will leak actually, but in ischemic cases, some of these ischemic cases, for example, in AEO, in anterior, you can have a sectoral edema that is can be very well differentiated with a fluorescent angiogram. So maybe done in cases of anterior ischemic optic neuropathy. So it has a role.
Sir, and in cases of VKH, when we are about to stop the treatment and clinically the patient is stable, would you like to repeat a ICG or FA at that point before stopping the steroids completely?
Yeah, actually, maybe better, but we are not using it. We are not doing it actually. Once the patient is has improved, we probably, unless there is recurrence, generally are not.
Okay.
Sunil sir, there's one question. What is the cause of disc leakage on an FFA picture?
Actually, there is no leakage of the FFA from the disc. Actually, in the late phase of the angiogram, you actually getting some staining of the glial tissue around the optic disc. Actually, there is no leakage in a normal angiogram from the disc.
Sir, thank you. I think what they meant was probably the new vessels on disc.
Yeah, only probably the new vessels actually leak. Actually, the normal disc have just a staining.
Dr. Mahesh, shall we conclude?
Yes, sir. Thank you, Dr. Sunil. That was a really wonderful talk. I think we were carried back to our PG days, where you used to, teach us each and every disease in a detailed manner. So very nice talk, and I hope the PGs have benefited from this. I mean, you have covered almost each and every disease, which will be, important for them in the exams, and with special emphasis on what are the pictures which will be kept. So that was really nice, and I now invite Dr. Dalia to give the vote of thanks.
And with so many clear pictures, I think it's explained so well all the stages of FFA or the layers of OCT. I think it's a great learning for all of us, not just the PGs. Thank you, sir, for your time. I also want to thank Dr. Divya for moderating this session in spite of technical difficulty. She's managed it well and making it a lively discussion. Thank you, PGs, for your good participation. We would like you to participate more and be more active in the next few coming sessions. Thank you, Dr. Mihir, for coordinating the whole program. Also, our Vice President, KOS Vice President, Dr. Nirupama, and KOS Secretary, Dr. Sujit, for planning the whole thing and full support. Last but not the least, I would like to thank Mrs. Chetana and Mr. Sargent from Sun Pharma for giving all the support. Thank you all. It was a very learning experience for all of us. Thank you.
Concludes the module 3 of our PG exam buster series. So next week we'll have module 4 at the same time, Saturday 7 p.m. So please join in. And thank you, Dr. Sunil, once again for the exclusive, PG teaching program. We have, I can make out you have put a lot of trouble in preparing these slides for the postgraduates. So thank you. Thanks a lot, sir.
Thank you.